Are you going to start now or?
Yeah, we'll just give it a couple minutes as people start.
Okay.
I could see the attendees going up there.
Oh, there we go. Yes.
Yeah.
Okay. We want to wait till there's.
That's right. Yeah. So we'll give them a few minutes to get going here, and then I will introduce you.
People are remarkably on time there.
Yeah, it's amazing.
Will you let me know, because you know the sun's going to set, I think, during my talk, and I've got lights on, but if I'm fading out, just let me know and I'll
Will do.
run and adjust it.
Okay, sounds good. Hello, everyone, and welcome. We'll just give it another couple of minutes here to hopefully have a few more people join, and then we'll get started. So we've had about 100 RSVPs. Looks like we've got 40 attendees so far. So we'll just give it a couple more minutes and then get started here. Okay, well, we'll just get started here. So firstly, I'd like to welcome everyone. I'm Jessica, the LTCI operations lead. So welcome to our very first virtual long-term care initiative learning series event. very excited to have you all here today. And thanks for taking the time. So I'd like to start with just a couple of housekeeping items. Please keep yourself muted at all time, just to ensure we don't get any background noise that's interfering. Our presentation today is case-based. So after each case, our presenter will answer your written questions. So if you'd like to submit those through the chat or the Q&A box, then we'll compile those and Dr. Gallagher will answer. If you have any questions during the presentation, please feel free as well to raise your hand. There is a hand raise button, so that'll pop you up to the top of the list and then we can manually unmute you as well. There are CME credits available for this event. So a member of the LTCI team will email you a certificate within a few days after. And finally, at the end of the session, there will be an evaluation. Please take a few moments to give us your feedback. It's of particular importance now that we have gone virtual. So we would like to learn as much as we can from this and move it and use those learnings to make each subsequent event even better. So now I would like to welcome our presenters, Dr. Romayne Gallagher. Dr. Gallagher has over 30 years experience in managing patients with advanced disease. She's retired as a physician in the Providence Healthcare Palliative Care Program and the St. Paul's Complex Pain Center in 2018. Dr. Gallagher is a clinical professor in the Department of Family Medicine at UBC and a member of the Division of Palliative Care. She was the founding director of the Division of Palliative Care at UBC from 1997 to 2003. Romayne Gallagher is the author and co-author of 50 peer-reviewed publications and book chapters on palliative care and pain management. So over to you, Dr. Gallagher. Thank you so much for being with us here today.
Thank you very much for having me, and I'm looking forward to this. First of all, I'm just going to share my screen with all of you so we can get started. Now, what I'm going to do is talk about, I guess there's the title. First of all, disclosure, I have no disclosures, which is, a long time. I've always had disclosures because I always spoke for companies producing opioids, but not anymore. None of us do. So I'm going to speak tonight for a little bit first about some new things in pain management, which I hope you will find interesting or useful. And then we'll move on to some cases. So in 2018, there was a really prolonged study that finished up in England, and it looked at over 6,000 adults and followed them for 10 years. And it looked just to see what happened to them. And what they found is that people who were often troubled with pain or had quite a bit of interference with the pain tended to die sooner. And on further analysis of the medication or of the data, they looked and found that what were the most common things was functional limitation. People who couldn't walk a quarter of a mile, which is really not that far. So people who were disabled to the point of not being able to walk, were physically inactive or poor self-rated health. And these were the most associated with mortality. So we do have quite good evidence indeed that pain does kill you, and it doesn't necessarily make you stronger. So where do we go from here? And I think the pandemic has particularly shown how declining socialization and declining function really has an enormous effect on people who are frail. And a lot of people say that, they saw a dramatic change in their loved ones with the stopping of visits and no activities in the facility. And this again sort of bears this out, that for whatever reason, when things affect our ability to interact with people and to get up and move around and do things, it really takes a toll on us. Just to remind you that there are two pain tracks in us. If you've forgotten, there is the spinothalamic one, which helps us to identify where the pain is. And those are the really fast fibers, the A fibers, where you touch I don't recommend trying this at home, touch your fingers on a hot stove and you quickly withdraw them. That helps us to identify the pain and quickly respond to it. Then there are the limbic pathways that actually sort of process and analyze the pain and its emotional impact. And both those tracks are very important. Now, recently, there's been a new definition of pain, and it's pain we've always known about, but we didn't know where to classify it. And you may remember that there was nociceptive pain, which is pain due to tissue damage, neuropathic pain, which is pain due to nerve damage, and damage specifically as well to the pain tracks. And then there were these other things like fibromyalgia, headaches, interstitial cystitis, pain from chronic fatigue, where we didn't really know where to place them. And they kind of fell between the cracks. But then we also had this other entity, which we called mixed pain. And, you know, many things are mixed pain. When you think about it, when you've seen someone with cancer pain, they usually have mixed pain because, say, for instance, someone with lung cancer would have metastases in the lumbar spine, but it might also be compressing on one of the nerves. So they would have mixed pain. But this calling it nociplastic is a relatively new thing, and I think it's probably a good thing because the definition for it is pain that arises from altered nociception, so altered awareness of pain, despite no clear evidence of tissue damage or threatened tissue damage, which is inflammation, causing the activation of peripheral nociceptors. And there's also no evidence for disease or lesion of the somatosensory system causing damage and misreporting of pain. So there's a number of these disorders which often are difficult to treat. And so these are now called nociceptive pain, and a person can have mixed pain, which is mixed neuropathic with nociceptive or nociplastic with, well, if it's nociplastic, it's going to be likely just on its own because it could measure up with tissue damage, but that would, depending on the pain, you could see two pains in one person. But the interesting thing about mixed pain, there was these practice pearls from this International Association for the Study of Pain, and really you could apply them to almost any pain condition. But obviously a diagnosis of mixed pain is based on clinical judgment, because at this point, we don't know whether, we don't have any way of diagnosing mixed pain. Like we can't check the blood or do a test that will give us a yes, no answer. But it's a good idea to consider that, gee, I can't work out the mechanism. This seems to be partly tissue damage, partly nerve damage, or I can't find any of it. When you've got mixed pain, consider early treatment with agents that target both mechanisms. So in other words, if somebody's got what sounds like neuropathic pain as well, think about your adjuvant neuropathic medications. And I think this is true for anybody with persistent pain, is that you need to perform an evaluation for comorbidities, such as comorbidities that affect pain. So that would be disturbed sleep, depression, anxiety, and pay attention to those things, because quite often mixed pain can be challenging to treat. And this is a way in which people will say, well, I haven't got rid of the pain, but at least I sleep now. Or I haven't got rid of the pain, but I don't feel as depressed. And, you know, oftentimes there's a way to improve the whole situation that way. Some of the things which people have been talking more and more about in pain in general is that pain and depression often occur together, particularly in older adults. And so you can see there, depression and chronic pain patients, 19 to 28%. And the question is neuroinflammation a common pathway for both disorders? Which would be very interesting. And we now know, we used to think microglia, the cells that surround neurons, just kind of sat there and, you know, held space. But they don't actually. They respond to inflammation, and when they become activated, they release cytokines, and that causes central sensitization. So these cells are by no means just placeholders. And but what that means is that depression may heighten pain perception and central sensitivity. And I think we all kind of intuitively know this. If someone is depressed, their pain is worse. And if their pain is worse, they're more likely to get depressed. And just to point out that these microglia, we now can measure when they become agitated or inflamed, so to speak, and that they begin to release the same chemicals that we see in inflammation. Now, the other thing that's becoming extremely interesting is that the way to a person's head is now through their gut. Sort of, you know, when you did say someone had their head up their ass, you really were now being truthful. And this really helps us to understand how stress can influence the brain. And basically, it can have effects on hormones, which can act on the pituitary and release chemicals through the adrenal gland, which have an impact on psychoactive substances that we're making in our gut. And they will in turn feed back into the brain and affect how we feel about things and so on. And some of the fascinating work that's coming out looking at lifestyle and environment and so on. So, and how our nutrition can affect us as well. I mean, there's a very interesting study looking at bipolar disorder and looking at fecal transplants in people with really bad disease to see if they can have an impact. And some small studies are suggesting it made quite a difference. So before I get going on pain assessment, any questions? Well, it doesn't look like there's any questions, so we'll carry on. I'm just going to put the chat out of the way. Okay, there we go. So let's start with our first case. So this is an 88-year-old woman admitted to residential care due to dementia. She previously lived in her own home, but alone. She was admitted to acute care with rapidly escalating confusion. She had complained of back pain, but she rapidly developed much more confusion and agitation and required admission. Her past medical history, she had hypertension, congestive heart failure, previous breast cancer that was treated, and non-insulin dependent diabetes. And she lived alone, always, no other family. In acute care, they treated a urinary infection, which they presumed was due to her, had caused her agitation. She had a chest X-ray and lumbar spine films suggesting abnormalities and suggesting she have a bone scan, but her agitation was so bad that they were really focusing on getting that under control. And she actually went up to a pretty whopping dose of olanzapine, 25 milligrams at bedtime. And they did put her on acetaminophen for the pain. The infection resolved, but she was unable to return home. And when she was admitted to residential care, the staff noted that she was difficult to mobilize and she was extremely drowsy. And they had been using NSAIDs for pain as the patient was thought to be too drowsy to add on opioids. So over the next 6 to 8 weeks, she was more alert, but still agitated and with mobilizing and care. She was given Tylenol 3 when she seemed in pain, but it didn't really seem to make any difference. She doesn't eat well and is losing weight. She wants to be in bed and resists being mobilized. So anybody have any suggestions as to the possible causes of this behavior? And you can either put it in the chat or you can just talk.
Hi.
Hi.
My first thought was that this lady's pain, if it would have been controlled better right off the start, she might haven't gotten to the stage where she's at currently, and all these infections like the UTI and the other issues. It seems like, and it sounds like that everything sort of originating from her pain. And I think if we would have paid more attention or would have actually treated her pain, she probably still would be able to mobilize and do other things as well. And she could, I'm not sure, but she could have been able to even return to her home if the pain would have been under control.
Yes, yes, I definitely agree with you. Anybody have any ideas what might be causing the pain? So what I'm going to do is just, I'll go on. Sorry about this. Every time I activate the chat, it stops my, there we go. So, you know, somebody looked through her chart and said, hey, they never followed up on these lumbar spine x-rays. And sure enough, she had multiple bony metastases from her breast cancer. She had some lab work done. She had raised tumor markers and unfortunately evidence of liver metastases as well. The message in this, I agree absolutely with most of you who probably thought, I wonder why they didn't treat her pain. And you know, this is the value in having family members because they would probably have remembered that she had pain prior to becoming really confused. And pain causes delirium. And you know, when you think of all the mnemonics for delirium that there are, none of them seem to mention pain. They mention infections and drugs and this and that, but pain absolutely does cause delirium. And one of the best studies you can find by Googling Morrison pain and delirium. And you'll find a very good study where they linked post-operative delirium to poor pain control. And it isn't just post-operative. I certainly have seen it in patients with cancer pain that's out of control, and certainly any kind of pain. The problem is that as we develop more cognitive impairment, our ability to report pain goes down. And if you look at the different kinds of dementias, some of them affect this more than others. So in Alzheimer's disease, really, the pain tracks are intact, but so the patient knows where the pain is, but the behavioral tracks get affected. So the processing and the understanding of pain and also the ability to communicate it is damaged. And so that's the problem with people not reporting it. So what we do know, I'm just checking my chat here. Pain, okay. So anyways, we do know that as people lose their cognitive abilities, they lose their ability to report pain. However, they do display behavior that if you tune into it, you can track to follow their behavior. And we'll talk about that in a minute. But what happens to these poor people who can't report pain is they do very poorly in acute care. And they often find that they get very poor pain control because they usually get way less medication, because many of the medications are PRN medications, and that's been shown again and again and again. I've certainly witnessed that, and you probably all have patients who've gone to acute care for treatment of something, and you found that they were given PRN medication where they couldn't really request medication or even understand that they were in pain. Now, there is an interesting tool, which, who knows, maybe the pandemic has held up this one as well because they were in the process of testing it. But it is called the EPAT pain assessment tool, and it takes a 10-second video of the person's face while they're doing something that would typically elicit pain. And then you key in other factors. You can key in some behaviors and things like that. You can also key in other sort of verbal behaviors and so on, and then known painful conditions. And then it kind of gives you a score. And so far, it looks pretty good. So, hopefully we will eventually see this. It kind of reminds me of Star Trek. But, I think you can develop this observational ability yourself, and you may not even say, oh, I saw an eyebrow go down or whatever, but you kind of know instinctively that person doesn't look comfortable, and you're really doing similar things to what the video is tracking as well. Now, I don't know what forms you have. I hope they're better than VCHs, because the tools that VCH have, they have one for verbally responsive patients, but many patients are verbally responsive, even though they might have quite moderate to severe cognitive impairment, right? So, and I've certainly seen patients who say, yes, they have terrible pain one day, and then the next day will say, no, I don't have any pain, dear. So that's kind of difficult. The form on the left side of the screen is a little bit more useful if you know how to use it. And that really is picking up a behavior that seems to indicate some kind of distress. And it's not necessarily, there's no one behavior that indicates pain. So it could be, calling out, it could be banging on the tray, it could be you know, resisting care, pinching people, doing whatever. Or it could be getting quiet, not eating, you know, all these things. I think it's much better if you get aggressive. You're far more likely to get your pain managed than you are if you get quiet or stop eating. But you need to, what happens is you follow this through pain intervention to see what happens. And now, but what I've seen are some of the problems is that particularly in the middle of the night, people go back and they say, oh, they're asleep. So they write down pain equals 0. Well, remember, just because somebody's asleep doesn't mean they don't have any pain. And so these are the kind of the drawbacks of all these forms that we have is knowing what to do with them and how to interpret them. One form which we found useful at Providence was aimed at the care aides, because they are the people who spend the most time with the resident, and they do a lot of the physical things which tend to induce pain. And it's been a while, but it may not be that much different. And because many of our care aides have English as a second language and are new Canadians, we often really overshoot in the instructions that we provide. And sometimes the instructions are not very helpful, so they have trouble following this. But nobody had trouble following this form. And I often found it very helpful to know that, say, for instance, when they gave the person a bath, they seemed to be in pain, or when they got them out of bed, or when they walked them to the toilet, etc. So all these things are very, very helpful. And you can download this. You don't have to have approval or anything like that. There's no, it hasn't been copyrighted. So I find from my own experience that it's wonderful if somebody has an observant family who, well, generally families are closest to that person and know, and they know what their pre-cognitive impairment behavior was. And it's very helpful to know. An observant care aide is wonderful to find, and many of them are very, very good at saying, I've noticed a difference. A bad day was always when I went in, when everybody says, this is my first day with the resident, because I think, oh, darn. But I think observing during care, mobilizing, and other pain-inducing activities is really helpful. And then I do look, you know, at what other medical problems people have, because do remember that congestive heart failure and COPD have up to a 50% chance of chest discomfort and so on. Chronic renal failure, people have up to a 50% incidence of chronic pain, and stroke as well, and cancer as well. So do keep this in mind, and keep in mind how common diabetes is with all its painful complications, and herpes zoster. The other thing that we're finding out is more about central pain, which we see a lot in people who've had strokes. And so people with who have damage to their spinal thalamocortical tracts may present with an exaggerated amount of pain. So, or more pain. I don't mean they're exaggerating it in a willful way. It's just that they have more pain. And we see this in vascular dementia, multiple sclerosis, traumatic brain injury, and spinal cord injury. The kind of person who tends to have increased risk is a person that we often see in our facilities, older age, female. They may have a comorbid depression. They may have used alcohol or diabetes or peripheral artery disease. They may have had vascular sort of embolic type strokes as opposed to hemorrhagic. And, you know, they typically, if they can talk to you, they can say, yes, my skin is very sensitive here when I touch it. It doesn't feel like when I touch the other leg. And that's allodynia. And hyperpathia is they may have evidence of arthritis in both hands, but would say, well, this side hurts more. So, but how are those going to present in someone with dementia, right? When you're looking at sort of, does somebody have pain or not, you really are looking at a bunch of sources of information. Resident report is really helpful if they can tell you. Family and caregiver, really helpful. Prior pain history, very useful, because oftentimes what's happened is people, they've been at a facility long enough that people sort of say, oh, you know, they've been here 2-3 years. What are they doing on all these medications, you know, and they say, do you have pain, Mrs. So-and-so? No. Well, and they say, you know, oh, in the interest of polypharmacy, let's stop some of these, you know. But you've got all these kind of clues, and you try and put it together and say, well, I wonder if they do have pain. And if it suggests, you know, if you sort of think, yeah, they may have pain, well, let's try a trial of analgesics, right? So what is a trial of analgesics? Is there evidence for it? So yes, there absolutely is. And I really clearly want to say that a trial of analgesics is not just acetaminophen. That's not it, because acetaminophen will help some people, but not everybody. And it's just not strong enough for a lot of people. So this is a trial which I usually mention. It's from 2011, and it's where they had a really sort of crude stepwise pain care protocol versus regular care, and then looked at agitation. But it's a big study. They got 352 people, which I think is pretty amazing that they all survived that long and could contribute to the study. What they showed is that those on the step-wide pain management, which did include, if acetaminophen didn't work, then they went to an opioid plus or minus pregabalin. And what they showed is by 8 weeks, people had a dramatic reduction in their agitation. And then they stopped the medication and returned to usual care. And you can see that the agitation begins to ramp up again. Here's a newer trial. This is in people who have less cognitive impairment, but it's still very interesting. And what they did is they took people with mild to moderate cognitive impairment, and they had severe pain not responding to acetaminophen or NSAIDs and sort of weak opioids. And for the people who had mild dementia, they were still able to score their pain intensity. For those who couldn't, they used behavioral indicators. And they put everybody on the same opioid, which is oxycodone, naloxone. And if people are not familiar with that, that's oxycodone with a little core of naloxone. And you might think, naloxone? I thought that kind of undid everything. But remember, naloxone is not absorbed from the bowel. So, and that was added not as a deterrent agent or whatever, but as to reduce constipation. Because the naloxone, takes care of the binding of the opioid receptors in the bowel, and it reduces constipation. And it comes in small doses of 5 to 2.5 up to 20 over 10. If you go above 60, say 60 over 30, most people will start to absorb enough of the naloxone that it interferes with the analgesia. So this is great for older adults because they usually don't have the need for the higher doses of opioids. And what they did with these people is they observed them for 45 days. And you can see here for the people who use the numeric rating scale on the left side of the screen, those people had a reduction in their pain. And for the people who were scoring by looking at their behavior, also had it. Now, someone has put in a good question here. Christine, this is a good one. Do you recommend adding PO naloxone on a regular basis for long-term care residents to prevent constipation? I used to do that when we were absolutely had no other, when someone had the most awful constipation, no matter how many laxatives you tried. The problem is naloxone is expensive, although it really shouldn't be. It should be dirt cheap. It's one of those things, that guy that got sent to jail for jacking up the price. I think someone should be in jail for the naloxone prices, because it's quite expensive, and it's difficult to know whether you're putting too much in and it's affecting their pain management. But it's a great idea, and there are now medications which are somewhat similar, which can undo the effects of the opioids in the bowel. What you've got to know, though, as well, is that not only do opioids cause constipation through the bowel, it's also a systemic effect, because as you remember, your patients who have transdermal fentanyl or buprenorphine, they also get constipated. So anyways, thanks for that. So they looked at their pain scores went down, and they also looked at their rescue analgesics. Those went down. The adjuvants, some of them went down. So maybe they were able to get rid of some adjuvants, BFI is bowel function, and it went down, which is pretty good considering you're titrating up opioids, right? It didn't go away. Their bowel function got better, but don't forget, a lot of these people may not have been on laxatives before. NPI is neuropsychiatric behavior, and look at the dramatic reduction in that, right? So whatever you call it, BPSD or neuropsychiatric or needs-driven behaviors, they went down dramatically. So it's pretty good evidence, not for this opioid in particular, but for opioids in general. The other thing that I found most interesting, because these people weren't as frail, they weren't all in residential care. And I've been thinking for a long time that if we caught people much earlier, would we improve their function? Because a lot of people say, opioids don't improve function. It's true, they may not improve function, but for some of our patients, it's so low, their function's so low that they need residential care. But look at this. This is the no, wait a minute, that's a gland. I think it's a functional index, and I'm just Barthen's, I think, index. And you can see, obviously here, independent needs minimal help, and then down to the darkest one, which is totally dependent. And look at the people, the change in people's function. I mean, that's quite dramatic. And it does make you wonder, you know, if this is a small study demonstrating that maybe if we caught people a lot earlier and kept them functioning better, then we wouldn't have so many people. Oh, and there it is. If I'd read the screen, BI is Barthel Activities of Daily Living Index. So anyways, it's a good study, a small one, but nevertheless well done. Any questions about those issues at all? Okay, then I'm going to press on. This next patient is an 81-year-old Chinese woman of Chinese descent who speaks little English. Right-sided CVA causing hemiparesis 7 years ago. So she's actually been in the facility for quite a while, for 5 years, in fact. And if you're able to find her old chart, you'd see that when she first came there, she used to resist care and be agitated, and she was treated with olanzapine, nortriptyline, paroxetine, Tylenol 3, and things settled. But then 5 years have elapsed, and she becomes less mobile and less communicative. And people are saying at the annual care conference that she looked awfully drowsy. So they thought, yeah, we should, look at this. She's on olanzapine, she's on paroxetine, she's on nortriptyline, and all of them can potentially make people sleepy. So 6 weeks later, she was agitated, eats almost nothing, anxious, and she was often taking off her clothes. And her son was very upset. He was wanting to have barium swallows or stick a tube down. Why wasn't she eating? All this stuff was going on. Palliative care was called because, it looked like the game was up, the show was over for this lady. So we looked back in the chart and sort of thought, oh, you stopped olanzapine 6 weeks ago. Did you know that kind of helps people to eat? So maybe you should just restart half the dose. So we did that. We also said, citalopram really doesn't do a thing for pain, not a thing. And in general, paroxetine maybe does a little for anxiety, but there's not a lot of evidence for the SSRIs. So we said, why don't you switch her to mirtazapine, which is an atypical, but like the SNRIs, it has an effect on the noradrenaline, and so that helps pain. And then, probably we spent a lot of our time talking with the son about preferences for care because, he'd got really upset and wanted everything done, and we needed to kind of talk this over for him because with the condition of his mom, it just, wasn't necessarily in her best interest. Comfort was in her best interest, so we did that. But has anybody got any ideas about why she might be taking off her clothes? What do you think was going on there? Anybody want to take a guess at that?
Hyperalgesia.
Yeah, well, yeah, allodynia. That's what you mean, I think, because hyperalgesia. Well, we can, and I will get to hyperalgesia because one of you did send in a request for this, and I will talk about that. But yeah, exactly, painful areas on the skin. And I think it was, she was taking off her clothes because she was uncomfortable. Now, we did have another lady who used to come out with hardly any clothes on out of her room and would be sent back repeatedly to try and get the poncho on above the waist, not below. and get a bra on and stuff like this. And that lady never wore many clothes at home anyways. So, you know, you have to be careful. You can't always take that, but this was new behavior for this lady. So it's a good thing to keep in mind if you see that kind of behavior. And remember, if you think about it now, it's not always going to be behavior. You know, if you're trying to communicate to somebody that you're uncomfortable or you were uncomfortable, you would take off your clothes. So that was allodynia. Let's see here. Where a non-painful sensation is painful. Hyperalgesia is where people start getting usually widespread pain. And we'll discuss that in a second. But this one was allodynia, so non-painful sensations were painful, and it's a sign of neuropathic pain. So it's a sign of her stroke-induced pain. So we actually started her on a tiny dose of methadone, 1 milligram Q12, and titrated up to a really tiny dose of 2 milligrams in the morning and 1 milligram in the PM. And she went back to, you know, our success was measured by the fact that she was eating all her meals, keeping her clothes on, and not anxious. And her son was very much content to not pursue a lot of investigation. So someone asked, Shelley asked, why did you choose methadone? Well, we knew it was neuropathic pain because we knew she'd had a stroke. We definitely didn't want to go with codeine, and I'll talk about that later. Methadone is a very good medication for neuropathic pain. And so we can usually get away. It behaves like a long-acting in frail older adults because it has such a long half-life. And you can get excellent pain control with tiny doses. And so that's why we went with that. Okay, so I think the key learnings of this were medications might be doing things that you don't realize or you've forgotten, that past medication history is important, and that when dementia reduces communication, look for signs of discomfort. So I'm delighted that someone put in a question saying, what's the deal with hyperalgesia? And I could go on for a while about this because, but I won't. What is hyperalgesia is increased sensitization and perception of pain. And a lot of people have begun to quote, you know, well, I increased the dose of opioid and the patient got more hyperalgesia, and it's been really promoted as another adverse effect of opioids, you know. Interestingly, analgesic tolerance is a different kind of thing, and the patient can often tell you, they'll say, no, my pain is the same. It's just that this medication doesn't seem to control it as well. And I put that up beside there because sometimes what I'm wondering is if what people are interpreting as hyperalgesia is in fact analgesic tolerance, which we still don't really understand that well. What we do understand is we hardly ever see it in older adults, and that's important for you to know. It's usually seen in young people. So you just remember that old neurons don't learn new tricks. So, you know, you're not likely to see this in a residential care patient. Where we do see opioid-induced hyperalgesia is animal models, experimental pain, and people on opioids for substance use disorder. it has a form of hyperalgesia has been reported in patients on opioid tapers, but I feel like saying, is this hyperalgesia, or people are just, acclimatizing to the fact that they're not taking as much opioid and their pain's a little bit worse, but they can cope with that. So it's all very interesting. So people have often wondered about that, because in my 30 years, I would say I've never seen this response. What I have seen is toxicity. And I don't know whether any of you have ever been caring for someone at the end of life where, and I've got the sun coming in dreadfully. I'm going to move over here a bit so I can, there we go. I don't know whether any of you have ever been looking after anybody who began to get more and more agitated as they were near the end of life. And oftentimes these people became acutely anuric. In other words, they stopped producing urine. So they had a really rapid kidney shutdown. And what happens is, because most opioids are excreted through the bladder, is that, or through the renal system, is that all of a sudden you have way too much opioid on board. And the person gets, is agitated, because usually the, particularly with morphine and hydromorphone, they are neuroadjuvants. And so sometimes I would see this and think, wow, they're really toxic. They're twitching, they've got myoclonus, they're agitated and so on. And the usual deal is just stop the opioid. They've got enough opioid on board, stop it and do something to kind of calm them down. Don't keep loading on the opioid. But of course, they're near the end of life. They're not really able to communicate with you because they're acutely delirious or in the final hours. So you really can't tell whether they feel more pain or whether they're just toxic and agitated. So, but what I wanted to say is that somebody reviewed all the studies that had looked at hyperalgesia, and they found a total of 2,706 subjects. And they only saw opioid-induced hyperalgesia in thermally induced pain, not with electrically induced pain, which is a little bit unusual, and meaning it's not very typical. And it was significantly more common in patients with opioid use disorder. So, put it this way, you're not going to see it in residential care. That'd be extremely rare. Secondly, most people, if you don't push an opioid that's not working or has intolerable side effects, rotate to something else, you won't see any trouble like this. The other thing is that you do see analgesic tolerance in younger people. And I used to have this in younger patients when I was treating non-cancer pain. And I would just rotate them to a different opioid, and they would resensitize themselves within a few weeks to that opioid. And that way I could just switch them back and forth between a low dose of two different opioids. But the patient themselves is pretty good at telling you, oh yes, it's the same pain, it's just that the medication doesn't work as well anymore. So it's all very interesting. There's lots of things we still don't know. Now, somebody did ask a question here. Yeah, renal shutdown, yes. You don't see it that often. That people's renal toxicity happens. And of course, we've got people all the time that have poorly functioning renal systems. And that's where the medications buprenorphine and methadone come in, because they are excreted primarily by the bowel. And so those medications are really, really good for people with very bad renal failure. Okay, so let's go to treatment. Oh God, I gotta hurry up. Okay, so I'm gonna give you all the slides. I'm not even gonna bother to say anything about non-invasive, non-pharmacologicals, because most of them, except for cold and heat and well, spinal manipulation maybe, and here I am going against what I just said. Most of these things require intact cognition, right? Like relaxation, CBT, all these kind of things. In an ideal world, they would be provided to everybody and paid for, and I hope to God one day that does happen. The evidence for analgesics in older adults, we actually have very few. It's a sort of an evidence-free zone. And there is one study just specifically looking at older adults, and it's getting quite old now. And what they found is, what have I done here? I'm going backwards. Yeah, what they found is that there was evidence for efficacy, but there was hardly anybody over the age that we deal with, right? I mean, we're in a real evidence-free zone. It's really hard to get people of 90 and 100 into your studies. The other point that this study made, which I thought was very true, is that the side effects of medications have much more importance for older people because, for instance, if something made you dizzy and you fell down, that would not be good, I suppose, if you passed out and you were driving a car. But if you tripped or something like that, no big deal. But if an older person who's frail trips and falls and breaks a hip, that is a life-changing event. And we should not only focus on the efficacy of drugs, but we should also focus on the adverse effects. So it's time to switch. Okay. So what I'm going to do is I just want to point out to you, I said acetaminophen was a somewhat helpful drug for some people. And I think there was another question. Someone said, should we continue acetaminophen with all of our patients, if we've got them on opioids? Here is a systematic review of acetaminophen. Quite a few people, variety of pain conditions. And what they found is that as a population, acetaminophen didn't really work that well. So in other words, it may work really well for individual people, but as a population, it didn't work that well. And I think, we sort of assume that if we put someone on acetaminophen, it's going to work. And of course, the main message of an analgesic trial is you can't stop at acetaminophen. Do I continue people? No, I stop them because you have to take 8 tablets a day. And who really wants to do that? It wouldn't be bad if they were like, I don't know, cannabis gummies or something like that, but they're just 8 more pills that you have to swallow and they may or may not be doing any good. So I tend to stop them. NSAIDs in older adults. NSAIDs have significantly higher all-cause mortality. There's significant risk of acute renal failure, and composite cardiovascular outcome is also higher as well. So really, the advice of the American Geriatric Society remains, don't use these in persistent pain. Use them for inflammatory pain only, smallest dose for the shortest period of time. and beware that all hell can break loose. So they're really not the drug of choice in frail older adults. So what about efficacy of opioids? We have about 8,690 patients. The big problem is that they're quite young compared to the age people get to now. They're not long studies. However, this meta-analysis did find significant pain reduction and some reduction in physical disability and some non-significant sleep improvement. Of course, there were lots of side effects, and that's part of the problem with opioids is you have to know how to manage the pain, but you also have to know how to manage the opioid too. And adverse events cause 25% of the people to stop the medication. So what about long-term studies? Because people have been very critical of no long-term studies in opioids. And, of course, nobody ever bothered to admit that the American, in order to get FDA approval, all you needed was a 12-week study. And that's why everybody did a 12-week study, because longer was more expensive. But there were some what's called enrolled enrichment trials where they take people who tolerate the opioid, and it seems to be helping. And they study those people. Now you might say, well, this is not a true trial of efficacy. Yes, in a sense, yes, and in a sense, no. But we need to look at these studies because we do have long-term evidence. And a lot of people wanted to just toss out all these studies and say, no, they're not adequate. But then you can't sort of say, look, everybody who starts on an opioid, eventually it's not going to work, etc. So what they found is that for the most part, the opioids did make a significant improvement in pain for those people who tolerated them and were able to go on them. And so we do have long-term evidence. And obviously these wouldn't be the people who probably would rapidly escalate their dose, and it's probably an ideal population. Again, we're not saying they're indicated for everybody, but there are some people who they're indicated for that they work well. And even the opioid use guideline for Canada would certainly say that if the person has moderate to severe pain and they're not getting benefit from the medication, you should go to a more higher dose. So I'm just going to have a look. Are all opioids the same? And I just wanted to point out this great study to you, which we had never done in Canada. And they did it in Italy, where they randomized 520 people to randomly receive morphine, oxycodone, buprenorphine, or fentanyl. They all had cancer pain. Mean age was 67. And they just kind of started them on this different medication and sort of looked at how they did. Interestingly, about 25% of anybody who was randomly assigned to an opioid just didn't tolerate it or needed it changed. So that's why you can't just go with one opioid, and I've had some people say to me, oh, I just use morphine on everybody. It works fine. And sorry, it doesn't really. But what they did see is that all opioids were not the same, and that there were several key issues. First of all, that more people stopped morphine due to toxicity, and that the risk of severe confusion was also quite a bit higher in morphine. And of course, we know it's neurotoxic, the metabolites, right? So it was really good to see something that mirrored what had been my personal experience of opioids. And this was a very interesting study. Of course, we do know that opioids are controlled by an awful lot of genomic factors. And so we do know that the genetic factors are associated with all these things: metabolism, transport, opioid receptors, and calcium channels and potassium channels. It's probably metabolism that affects the most. And of course, that one is codeine, which requires metabolism to an active ingredient. And that one is probably the one that has the most risk of genomic changes that have a marked impact. So I think what I'm going to do is I'm going to skip this case because I think we'll go by that one. So what are the opioids of choice in frail older adults? Well, if we look at them all, we know that hydromorphone is better than morphine and codeine, and I'll explain, followed by oxycodone, fentanyl, methadone, and buprenorphine. Those are the drugs of first choice, primarily because oxycodone, fentanyl, methadone, and buprenorphine do not have active metabolites that hang around and cause problems. But morphine and codeine do. Now, speaking of another weak opioid, tramadol, and this is both an opioid agonist, plus it inhibits the reuptake of serotonin and epinephrine. And the only problem is, though, it's a weak opioid because just like codeine, it requires metabolism to become active. So if it needs that, then its ability to reach, you can't have a linear relationship between dosage and effectiveness because its metabolism is limited. It's metabolism to an active ingredient. And so that's why tramadol has been placed as the drug of first choice, is because it's limited by an enzyme. It's a weak opioid, just like codeine. It's far less likely to be abused because it's not very interesting, because you rapidly reach the maximum dose and you don't get any more effect from it. So what we are finding, though, is that when this became the #1 recommended medication, even for older adults, which really bothered me, because it really isn't based on evidence. What we began to see is all the same problems that other opioids would have with older adults, and so risk of falls and delirium and accidents and problems, the same as any of the other strong opioids. And it works really well for some people, just like acetaminophen works really well for some people, but as a population, it's a weak opioid, and I certainly don't recommend using it. Now, where did my slides on? Okay, well, for some reason, I'm not talking about codeine, methadone, codeine, morphine, and hydromorphone. The main thing to know is they all are very much dependent on renal function because their metabolites are neuroadjutants. And if you can't clear them very well, you're going to get delirious. And so that's often what we find. Hydromorphone is better tolerated than morphine because it has a shorter half-life, but really it's not that much better. And if you need higher doses, you can get the same kind of delirium. So fentanyl patch, a lot of people say, oh, I can't really use this in residential care, it's so strong. But you know, now that there is a 12 microgram patch, and you can get a half of a 12 very easily now because the matrix patches have the backing on them that's exactly half. That, you know, really only equals 3 to 4 T3s a day. And a lot of people who are on PRN, whatever, will be able to make the leap to fentanyl if they seem to have persistent pain. So quite often that works very well. The only people it doesn't work very well in are really skin and bone people. You need a significant amount of fat on you to maintain a store of that medication. Just about everybody knows about sufentanil for incident pain. The only thing I offer as a suggestion here is don't forget that people can't follow directions when they have cognitive impairment. And so getting someone to hold something under their tongue for a minute, oftentimes they just swallow it. And if they swallow it, it's useless because it's not well absorbed orally. So you can use this great nasal atomizer that works really well and you know you've got the dose in. You just spray half up each nostril. Here's this oxycodone naloxone CR tablets. As I mentioned, it comes in small dose sizes. It's not covered by pharmacare, but you know, oftentimes families are willing to pay for their loved ones to have this if this works well. And then buprenorphine patch, partial agonist of a mu receptor. We still don't really understand all the pharmacokinetics because we thought of this drug as a partial agonist because you seem to reach a ceiling effect on the respiratory depression. But people also thought you reached a sort of analgesic tolerance as well, but not necessarily. The patch is very different. It's very tiny doses. I'd consider it no more than a weak opioid only because it comes in small doses. It works really well in older patients, and you can start it in opioid naive patients because it has such a slow onset. Now, someone did ask, what do you do if someone's taking high dose buprenorphine for opioid use disorder and then they have acute pain? There's several things you can do. First of all, it'd be well, you never know. You never know. You may see these people in residential care just because they have no other place to go sometimes. And that does happen. But generally, there's several options. You can temporarily increase the buprenorphine, say from a dose of 24 milligram tablet, you can go up to 32. You can add on things like ketamine for pain, which can be very, very helpful, even though it's partial anesthetic. You can use sub-anesthetic doses, which can help. And then the other thing you can do is go to a buprenorphine infusion, which when you do that, it quite often you can get good analgesia that makes you wonder whether it is a partial agonist or not. So it's still to be worked out yet, but there are a number of options. But this patch, again, not covered by pharmacare, but oftentimes families will pay if it means that their loved one is comfortable. Methadone, well tolerated. I said why I tended to use it because well tolerated. You never go near the doses that cause arrhythmias or anything like that with older people, and you quite often get really good pain control with pretty small doses, and it's generally well tolerated. The point I want to make, though, about long-acting opioids is I quite often find it's pretty difficult to order Q4-hour opioids in residential care and expect the nurses to be able to actually carry that out, because it's just very difficult. So I quite often start people off with long-acting opioids, because when you think about it, an oxycodone SR 5 milligrams only equals 1.5 T3s over 12 hours, and that's a tiny amount. We wouldn't hesitate to start 3 T3s per day in an older adult. Methadone is equivalent to a pretty tiny dose when you start at 1 milligram. And again, a half of a 12 microgram fentanyl patch is only 5 T3s over 24 hours. So really those aren't too bad. And buprenorphine patch is safe in opioid naive. So I often do this because for one reason, it makes it easier for the facility to carry this out. Second of all, long-acting opioids have fewer side effects, because the dose, when you think about it, when you're giving short-acting opioids, the serum level is going up and down and up and down. And quite often I would get calls where the nurses would say, you know, they're dozing off about an hour after I give them their short-acting. And that's because, you know, the serum level fluctuates, because as we all get older, our blood-brain barrier gets leaky, and so we get more of that stuff in our CNS, and we're more susceptible to dozing off. So older adults actually have fewer side effects with long-actings. Don't forget topical opioids, which work quite well. And I've got some pictures there of a guy who had a whopper of a basal cell carcinoma and how we dealt with the pain from that, because you can see it's almost down to the bone there. And we would just cover it with methadone powder, and that worked well. Oh, cannabis for neuropathic pain. Well, we're getting some better studies now. There are some very old small studies of it working quite well for the neuropsychiatric symptoms. The only problem is you really need to use only the cannabidiols, because the THC just gives too much sedation. So one other comment I wanted to make is it's better to stay away from gabapentin and pregabalin because few reasons. One, it makes people dizzy and nauseated. And I'll tell you, a lot of older adults, as you know, we're already dizzy and they get easily nauseated. So they really don't like it. And second of all, it really is, think of it and remember that it's a calcium channel blocker. And remember fluid retention with calcium channel blockers. I've had people say, I peed out 40 pounds of fluid after you took me off that medication. So do keep this in mind, that they're not always the best. And, you know, really you do better with SNRIs or mirtazapine. Now I see that somebody has asked me a question. Oh, how do you order methadone powder? So if you're going to use this, and I have, what I'll do is I will send Jessica the paper that I wrote, and it has the recipe. It's 1% powder, and I will send you this because you have to be able to estimate how much powder to make up. So I will send that tonight after we're done. You know, it got to the point where we used it so often in Providence Healthcare that they just kind of knew and they just did it. You know, it works really, really well, especially for people who are getting very drowsy, because basically they're on this systemic opioid for something that's very localized. And oftentimes those lesions have very poor circulation. So you're using something systemically, but it's not really addressing the pain in the peripheral nociceptors there. And one final point here, a lot of the time, particularly if you've had people who've been on opioid or on neuroleptics for agitation, because agitation is how their pain is manifesting. If you put them on an opioid and suddenly they get pain relief, what do? They fall asleep because all of a sudden they have all these CNS depressants on board. And what happens is that you get a call from the facility saying, oh my gosh, that opioid has made them really drowsy. And I finally realized, oh no, that's not the opioid. That is all the other stuff that other people tried to help their agitation. So when I start an opioid, I often back off on a lot of those other CNS depressants. And keep on backing off on them because, quite often that you'll find that if it is pain and you get rid of the pain, they need a lot fewer medications. And I've even seen people's mini mental status numbers go up. And you know how crude of a tool that is about cognition. It's very crude. So if that improves, it really shows you what getting pain under control can do. So I think I'm missing out a case here, but I think it's important to stop for questions. This was a case of where you can't tell the difference between pain and depression. The person's complaining of pain, but they probably got depression. So just a reminder that oftentimes people benefit from that. And there's a whole long case with this, which I won't do. I also make a plea not to forget things like vertebroplasty and epidural steroid injections, which can work really, really well in seniors and can spare them using the systemic medications and can work quite well. So, putting a little bit of cement in there can make a great deal of difference. And then just want to promote our palliative care app. It's called iPal, and you can just Google it there and download it on your smartphone, and it's got all the medications you need for managing. It's useful for chronic pain in older adults too, and it's very useful for palliative care. So, and it's a website-based app, and it's completely free. So I'll stop there and take any questions. So if you could just talk, I guess, if you've got a question. It looks like hunger has overcome everybody. Oh no, wait a minute, there's something. Oh, okay, just go ahead and unmute yourselves. Well, hopefully everybody's not, well, of course you guys can get up and get your dinner, can't you? Unless you're at the office, but you're probably at home. So if there's no questions, I will send, thank you. I will send that paper about the topical methadone, and the other papers that I've mentioned are all referenced in the slides, and I think Jessica's going to send you the slides. Oh, here we are. Oh, yes. Any tips for residents that refuse to take medications, anxiety, paranoia, and chronic pain? Oh boy, that's a toughie. Well, what I do you know how, particularly if someone is incapable of making decisions, and they don't have any family. So let me give you a patient we had. She had a stroke at age 29. She had one of these very bizarre syndromes, and she managed essentially to drag herself around all these years. But as she got older and weaker, she just couldn't do it. And there she was in bed. We knew she had terrible pain. She would tell you how terrible her pain was, but she would not touch any medication. And she was thin as a rail. So part of me thought, can I get a fentanyl patch on her, where she couldn't take it off on her back? But it just wouldn't work for her. So what we basically did is had a staff meeting where we said, look, we really feel it's in the best interest of this lady to take this medication, and she won't take it because she just says, I don't need any medications. And so we talked it all through, and we could have called ethics in on this, but what we did is we basically spiked her coffee with methadone twice a day. And it made a huge difference. Now, I don't know, I'd be very interested to know, because I'd be very interested to know what you guys thought of that, because we felt that we had acted in the best interest of the patient. We undertook a trial. We asked her if she felt better, if her pain was better. Yes, it was. And we documented it all, etc. Oh, thoughts on patients who have behavioral problems, sexual inappropriate behavior, and pain. Do you mean that you can kill two birds with one stone, fix the, control their pain and affect that? Oh, that's interesting. Well, the thing is that if they were young and you gave them opioids for long enough, you really affect their testosterone. And then the sexual inappropriate behavior would stop. But the problem is that in frail older adults, you just don't do that. Now, are you thinking that maybe their sexually inappropriate behavior is occurring because of pain? I suppose it could be, and that would be a fascinating case report. Because when you think about it, I suppose if you were successful in your sexual behavior, you would release endorphins, and I suppose it would help you to feel better. It would make a great case report. I must admit, I've never seen sexually inappropriate behavior reported as being caused by pain, but there's always a first time. Now, I have seen here somebody said, how long of a trial do you give before you switch to a different opioid due to ineffectiveness? Thank you for asking that. I usually push the dose until I see drowsiness, because I have been absolutely stunned sometimes by the amount of pain a person must have had, because they kept getting better and better and better as we increase the dose. So I usually go up to the point of where they're getting a little bit drowsy and then back down to the dose below that and stick with that dose. If you find, though, that you're going up in the dose and the behavior just isn't changing, then I rotate to a different opioid. And I do try, so it's always a good idea not to say, oh yeah, I've tried one opioid, it didn't work. So forget all opioids, because I think I've made the point that they're all different, right? So sometimes you need to try more than one. And I have sometimes tried 3, and then bingo, we hit a good one, and the person, way more settled. We actually found out that that they spoke Cantonese because they hadn't been using any Cantonese. All they would do, their agitated behaviors, they would just shout out, hello, hello, hello. But it turned out that was the only English word they knew. So it's fascinating. So is the use of buprenorphine common in elder patients? Well, do you mean the sublingual? No, that's not common. The patch is more common. Some people have said, oh, well, you can just put them on the sublingual. And, you know, to be honest with you, I got so mad once because one of my patients who was Muslim and, of course, would never use alcohol or drugs, that was very important to him, right? And the pain team at another hospital, which shall remain unmentioned, decided they were going to just substitute him on sublingual. And I said, well, you know, first of all, he has dementia. That's why we took him off pills and put him on a patch. Second of all, if he found out that he was put on a medication that was given to drug abusers, can you imagine how he would feel, right? I mean, can you imagine how most people would feel, would say, what, you know? So anyways, what's my favorite antidepressant to use in someone with pain? Mirtazapine. The reason being is most frail older adults have a number of problems. They have pain, they don't sleep very well because they have pain, they don't eat very well because they have pain and they're frail and fragile. Mirtazapine deals with a lot of those. You can sort of kill several birds with one stone there, right? You can improve their appetite and improve their pain and improve their mood. Do I educate employers who believe narcotics hasten death? My goodness, you know, that's a real sad going backwards, isn't it? And that's happened with the opioid epidemic, which is really not an opioid epidemic. It's a poisoning of the illicit supply and an inadequate treatment of opioid use disorder. But anyways, yes. Yeah, I think that's really problematic when people feel that way. So anyways, thank you. We'll send it out for you, and it's been a real pleasure. Thanks for all your great questions. And you're more than welcome. Thank you. Bye-bye.
Thank you very much, Dr. Gallagher. Thank you.
Okay, you're welcome. Bye-bye.
Have a wonderful night, everyone.